So, welcome to Kanski lecture series Cornea part 17, and in this part we are going to discuss about the corneal dystrophies. So basically the corneal dystrophy is a problem in the cornea that is basically hereditary, and when it is hereditary, you know that both the corneas are going to be affected. It is bilateral, it is usually symmetrical but can be asymmetrical as well, and also it present earlier in life than any pathology of the cornea. So let's get started. Corneal dystrophy. Corneal dystrophies are a group of progressive, usually bilateral, variable corneal opacifying disorder, many of which are associated with decreased vision and discomfort. So they are going to be the opacities of the cornea. It involves the different layers of the cornea. Based on biomicroscopical and histopathological features, they are classified into epithelial, Bowman's layer, stromal and Desmond membrane, and endothelial. One or more underlying genetic abnormalities have been identified for most. As a general rule, most type of corneal dystrophies are bilateral, primarily affect one layer of the cornea and are slowly progressive. So we are going to divide the corneal dystrophy based on the the layer of the cornea which is affected. So when it affect the epithelium, it can affect the Bowman's layer, it can affect the stroma, it can affect the Desmond membrane, and it can affect the endothelium as well. So first of all, we are going to study about the epithelial corneal dystrophies. So let's see, epithelial corneal dystrophy, there are of two types. That is a Cogan, number one, and second is a Meesman. So just remember this, Cogan and Meesman are the epithelial corneal dystrophies. Epithelial dystrophy, Cogan epithelial basement membrane dystrophy. Isolated familial cases of epithelial basement membrane map dot fingerprint corneal dystrophies have been reported. So why it has so many names? It can be caused the Cogan epithelial basement membrane. The thing is, it can, when it appear, it can have a map like configuration, or it can be like a dot, and it can be like a fingerprint, like you can see that a finger are printed, and when you see the layer, it is the epithelial basement membrane. Since most patients seen in clinical practice have no documented family history of the condition, these corneal changes are now considered degenerative or secondary to trauma. The disease is often misdiagnosed, particularly because of the variable appearance. The condition is usually sporadic, and in these cases may be degeneration rather than true dystrophies, in contrast to the true familial autosomal dominant cases. So according to the inheritance, it is sporadic. Let me tell you, because it has not no certain gene has been identified to cause the this dystrophy, so it is now be considered as a degeneration rather than a dystrophy. But for now, we usually study it under the corneal dystrophy. Histology. Histology show the thickening of the basement membrane with the deposition of the fibrillary protein between the basement membranes and the Bowman's layer. Basal epithelial cells, hemidesmosomes, are deficient. So when we see the histopathology, you can see that epithelium basement membrane are thickened, and also the hemidesmosome are those which attach the epithelium with the underlying basement membrane. These are also deficient, and also you can see there is a deposition of the fibrillary protein between the basement membrane and a Bowman's layer. Onset is the second decade. About 10% of the patient develop recurrent corneal erosion in the third decade. The remaining are asymptomatic throughout the life. The occurrence of the bilateral recurrent erosions with no history of the trauma suggests a basement membrane dystrophy. So basically, most of the dystrophy have the symptoms of recurrent corneal erosion syndrome, and also it present earlier in life, about second and third decade. Lesions are often best visualized by retroillumination or scleral scatter. So these are basically the slit lamp examination techniques, retroillumination and scleral scatter. Over time, pattern and distribution varies. They may be absent or subtle in the fellow eye. Similar features can be seen with recurrent erosion from any cause. So you have to remember dot, map-like, and fingerprint because these are the how it presents. Dot-like or microcystic epithelial lesion. So there will be like a dot-like or epithelial cystic lesion in the corneal epithelium. Subepithelial map-like pattern with the faint haze, hold fingerprint-like pattern, bleb-like subepithelial pebbled glass pattern. Treatment is similar to that of a recurrent corneal erosions. So we are going to see the figure 7.48 for that. So, corneal epithelium and subepithelial dystrophies. A is a histology showing intraepithelial extension of the basement membrane above the intraepithelial cyst, toluidine blue stain. So, this is an intraepithelial cyst, and you can see that there is an extension of the basement membrane. Cogan and B is showing the Cogan dot and microcystic. So this is like dots and microcystic. And C is showing Cogan map like configuration pattern. So this is a map like pattern. And D is a gelatinous drop like dystrophy. This is some other kind of dystrophy. So next is a Meesmann epithelial dystrophy. Meesmann dystrophy is a rare, non-progressive abnormality of the corneal epithelium metabolism. So you are going to see that there is a problem in the metabolism of the epithelium, underlying which mutation in the gene encoding corneal epithelial keratins have been reported, and the underlying gene which is responsible are the corneal epithelial keratins. Inheritance is autosomal dominant. Histology show irregular thickening of the epithelial basement membrane and the intraepithelial cyst. So what are in this? There will be the thickening of the basement membrane and there will be the intraepithelium cyst. Symptoms: patient may be asymptomatic or there may be recurrent erosions and blurring, usually mild. Myriad tiny intra. So whenever you see that there are intraepithelial cysts in a younger patient, you can always think of a Meesmann corneal dystrophy. And one of this, that it also extend toward the periphery as well, but they do not reach the limbus. Myriad tiny intraepithelial cyst of uniform size but variable density is maximal centrally and extend towards but do not reach the limbus. So there will be the intraepithelial cystic. The cornea may be slightly thinned and sensation is reduced. So there will be the reduced sensation with it. Treatment other than lubrication is not normally required. So you can see figure 7.48E is showing a histology showing thickening of the epithelial basement membrane and intraepithelial cyst passed in. So there is a thickening of the basement membrane and you can see the intraepithelial cystic spaces. F is showing the Meesmann myriad intraepithelial cyst. So you can see that there are small cyst like thing present in the cornea. And G is showing the leash gray band with hole configuration, and H is leash retroillumination showing densely crowded microcyst. So basically these are leash is another kind of epithelial dystrophy. We are not going to discuss it here. Other epithelial and subepithelial dystrophies are leash epithelial corneal dystrophy, subepithelial mucinous corneal dystrophy, and gelatinous drop-like corneal dystrophy. So these are the corneal other epithelial corneal dystrophy. Now next is going to be the Bowman's layer corneal dystrophy. So in this part there is also two types, Thiel-Behnke and Rees-Buckler corneal dystrophy. Let me tell you that these are most of the time they are presentation is same, but only thing that differentiate them is the microbiology or histology. Bowman's layer or interior stromal dystrophies, Reese-Buckler corneal dystrophies, they may be characterized as an interior variant of the granular stromal dystrophy, granular corneal dystrophy type 3. So, Reese-Buckler is also known as granular corneal dystrophy type 3. And it is also known as the corneal basement dystrophy CBD1 type 1 as well. Inheritance is autosomal dominant. The affected gene is TGFB1. So the affected gene is TGF1B1. This is very important and you have to remember this. Replacement of the Bowman's layer by the connective tissue band. So what is the problem here going on? That there will be the Bowman's layer will be replaced by the connective tissue band. Symptoms are the severe recurrent corneal erosion in childhood. Visual impairment may occur. Signs: gray white geographical subepithelial opacities, most dense centrally, increasing in density with the age to form a reticular pattern. So there will be the subepithelial opacities that are going to be very dense in the center of the cornea, and they are going to increase in density in the reticular pattern. Histopathology, including electron microscopy, may be required for definitive distinguish from the Thiel-Behnke dystrophy in some cases. So I told you earlier that the Reese-Buckler and Thiel-Behnke are usually differentiated mainly on the basis of the histology, because electron microscopy, because they are distinguished in there. Corneal sensation is reduced. Treatment is directed at the recurrent erosion. Excimer keratectomy achieve a satisfactory control in some patient. So you basically do the symptomatic treatment, you do lubrication, and you do about the recurrent erosion, how you treat the recurrent erosion syndrome. Thiel-Behnke corneal dystrophy, also termed as a honeycomb shape corneal dystrophy and corneal basement dystrophy type 2, features are generally less severe than Reese-Buckler. So these are known as a corneal basement dystrophy 2. Inheritance is same as that of the Reese-Buckler, autosomal dominant gene TGFB1 and at least one other. Bowman's layer curly fibers on electron microscopy. So what are you going to see on the electron microscopy? There will be the curly fiber. So that is how you differentiate between the Reese-Buckler and the Thiel-Behnke corneal dystrophy. Symptoms are recurrent erosion in childhood. Subepithelial opacities are less individually defined than a granular dystrophy type lesion seen in Reise-Buckler dystrophy. They develop in a network of tiny rings or honeycomb like morphology, predominantly involving the central cornea. Treatment is not always necessary. So let us look at the picture. 7.49 is showing the Reese-Buckler dystrophy. A histology is showing the replacement of the Bowman's layer and the epithelial basement membrane by the fibrinous tissue. B is showing the typically moderately discrete geographic opacities. So you can see that the basement membrane is replaced by the connective tissue, and this is how it presents. Thiel-Behnke, you can say the honeycomb-like appearance in the center of the most dense around the center of the cornea. Now next is a stromal dystrophy. So stromal dystrophy, very important. You have to remember stromal dystrophy, lattice and granular. So lattice corneal dystrophy type is divided into type 1 and there is type 2. In type 1 it will purely corneal disease, and in type 2 there will be the systemic involvement as well. So that is how we divide the lattice corneal dystrophy into the two types. So the stromal dystrophies are lattice corneal dystrophy TGFB1. So TGFB1 gene is very important. It is basically involved in most of the cases of corneal dystrophy. This is usually regarded as the classic form of lattice dystrophy. Clinical variants 3A associated with more than 25 heterozygous mutation in TGFB1 have been described. Inheritance is autosomal dominant gene TGFB1, amyloid staining with Congo red, and exhibiting green birefringence with a polarizing filter. So one thing you have to remember with the lattice dystrophy is the one mnemonic, that is the LACity. LACity. What is that? L is for the lattice. A is for that there is an amyloid deposition in the lattice dystrophy, and city means that C means that they will stain by the Congo red stain. So basically the lattice dystrophy is autosomal dominant, and there is an amyloid deposition in the stroma, and that stain with the Congo red. What is the Congo red? Because how does it, when the polarizing filter is passed through it, it shows the green birefringence. Symptoms: recurrent erosion occur at the end of the first decade in the classic form when typical stromal signs may not be yet be present. Blurring may occur later. Refractile anterior stromal dots coalescing into a relatively fine filament lattice that describe gradually but spares the periphery. So basically, you can see like there will be the dot like, and then it will typically define the lattice type pattern. A generalized stromal haze may progressively impair vision. Corneal sensation is reduced. Treatment by penetrating or deeper keratoplasty is frequently required. Recurrence is not uncommon. So, how do you treat? You do the deep anterior lamellar keratoplasty for this type of dystrophy. Let's see figure 7.151. So this is a 7.51 is showing the lattice dystrophy. A is histology showing the amyloid staining with the Congo red. So you can see that there is a amyloid staining with the Congo red. B is showing the green birefringence of amyloid when viewed through the polarized light. And C is showing the lattice dystrophy type 3A. So you can see like this is the pattern, that is here glassy dots in the interior stroma in type 1, the fine lattice line in type 1, early central stromal haze in type 1. Now next is a lattice corneal dystrophy Galzoline type. Because of the gene that is associated is the Galzoline gene, so it is known as a Galzoline type. Now the thing is, I already told you that it is a pure corneal dystrophy, and in this case there will be the systemic involvement as well. Just remember this, and it is also known as a Miro-Toja syndrome. Lattice corneal dystrophy Galzoline type, also known as LCD2D2 and Miro-Toja syndrome. This is a systemic condition rather than a true corneal dystrophy. Inheritance is autosomal dominant gene GSN. Histology showing the amyloid deposit in the corneal stroma. Ocular symptoms: ocular irritation and the late impairment of the vision. Erosions are rare. Ocular signs are the sparse stromal lattice lines spread centrally from the periphery. So remember that the type TGF1B type does not have involve the periphery, but this involve the periphery as well. Corneal sensation is impaired. Systemic features is a progressive cranial and a peripheral neuropathy. So progressive cranial and peripheral neuropathy, mask-like faces and autonomic features. Homozygous disease is rare, but remember that in with the second type there will be the peripheral neuropathy or the cranial nerve involvements. Treatment is keratoplasty may rarely be required in later life. Now next is a granular corneal dystrophy type 1 classic. So next we'll have a granular corneal dystrophy type 1 and then type 2. Basically type 1 is a pure granular corneal dystrophy, and in type 2 there will be the mixed type of the corneal dystrophy. There will be the lattice as well as there will be the granular corneal dystrophy. So these are known as granular corneal dystrophy type 2. And also in the case of a granular corneal dystrophy, You have to remember one mnemonic. You have to remember the mnemonic goes more head. Granular is basically there is hyaline deposition in that, and that is stained with the Masson trichome. Always remember this. Granular corneal dystrophy type 1 classic in autosomal dominant gene TGFB1 homozygous disease give more severe features. Histology amorphous hyaline depositive staining bright red with Masson trichome. Glare and photophobia with blurring as progression occur, recurrent erosions are uncommon. Signs are the discrete white central anterior stromal deposits resembling sugar granules, breadcrumb, or glass splinters separated by the clear stroma. So, the in a case of granular dystrophy, you can always see that there will be an intermediate clear stroma, and there will be the dystrophy opacities like in a shape of a granule, breadcrumb, or sugar granule. Gradual increase in size and number and size of the deposit with deeper and outward spread, sparing the limbus. Gradual confluence and diffuse haze lead to visual impairment. Corneal sensation is impaired. Treatment by penetrating or deep lamellar keratoplasty is usually required by fifth decade. Superficial recurrences may require repeated excimer laser keratectomy. So you can always do in a case of stromal dystrophy, you can always think about the keratoplasty, because you have to remove the diseased cornea and you have to put the healthy cornea in it. Next is a picture that is showing 7.52 granular dystrophy type 1. Histology showing the red staining material with Masson trichome. B is a sharply demarcated crumb-like opacity. C increase in number and outward spread, and D is the confluence of the opacities. Granular corneal dystrophy type 2, also known as Avellino and a combined granular lattice dystrophy. So I told you earlier that it has basically a mixture of both lattice and granular dystrophy. You can see both amyloid and hyaline in it. Inheritance is autosomal dominant gene TGFB1. Histology show both hyaline and amyloid. Symptoms are recurrent erosion, tend to be mild. Visual impairment is a later feature. Signs are usually present by the end of first decade in heterozygotes. Fine superficial opacities progress to form the stellate or annular lesions, sometimes associated with deeper linear opacities. So basically, there will be the small opacities that will become a linear or stellate in appearance. Treatment is usually not required. Corneal trauma, accelerate progression, refractive surgery is contraindicated. It is very important in which case the cataract surgery, refractive surgery is contraindicated. It is the Avellino dystrophy. So you can see figure 7.53 granular corneal dystrophy type 2 Avellino. You can see both lattice and the granular dystrophy. Next is a macular corneal dystrophy. So it is like Marilyn Monroe made. So basically its mnemonic is Marilyn Monroe made. So you are going to see the macular corneal dystrophy that will have a mucocutaneous deposit, and then it stains with the So they stain with the Alcian blue or a colloidal orange. Basically, M is for mucopolysaccharide. Macular corneal dystrophy is an autosomal recessive. So we have usually studied the autosomal dominant, but now it is an autosomal recessive. Gene is CHST6. The condition is relatively common in Iceland. Histology showing the aggregation of the glycosaminoglycans intra and extracellularly stained with Alcian blue and colloidal iron. Early end of symptoms are early end of first decade. Visual deterioration, recurrent erosions are very common. Signs are dense but poorly delineated. grayish white centrally in the anterior stroma and peripherally in the posterior stroma. So very important that centrally it is involving the anterior side of the stroma and periphery it is involving the posterior side of the stroma. There is no clear delineation between opacities which may be elevated. Progression of the lesion occur in conjunction with the anterior stromal haze, initially involving the central cornea. There is eventual involvement of the full thickness stroma extending to the limbus with no clear zone. So this is important that a macular dystrophy and a Meesmann both remember that they extend to the periphery. There is eventual involvement of the full thickness stroma extending to the limbus with no clear zone. Thinning is fairly early feature with late thickening from edema due to endothelial dysfunction. Sensation is reduced. Treatment is with the penetrating keratoplasty. Recurrence is common. So you can see figure 7.54. Macular dystrophy histology showing the deposition of the abnormal glycosaminoglycan appear blue with the colloidal iron stain. B and C show the poorly delineated deposit increasing in number, increase in size and confluence of the lesion with the stromal haze. So remember that the macular corneal dystrophy involves the periphery. Next is the Schindler crystalline corneal dystrophy. This is a disorder of the corneal lipid metabolism associated with some patients with the systemic dyslipidemia. The use of crystalline in the name is no longer recommended as corneal crystals are not a ubiquitous feature. So basically there is a problem in the lipid metabolism in this case. And it is associated with the systemic dyslipidemia. Inheritance is autosomal dominant and gene is OBAID, UBIAD. Histology showing phospholipid and cholesterol deposit. Symptoms include visual impairment and glare. Signs are the central haze is an early feature progressing to more widespread full thickness involvement over time. Subepithelial crystalline opacities are present only in around 50%. Prominent corneal arcus is typical and gradual progresses centrally leading to diffuse. So whenever there is a dyslipidemia, you will always think of the corneal arcus. It is very common in the case of the lipid dystrophies. Treatment is by excimer keratectomy or the corneal transplant. So you can always do some corneal transplantation in a case of stromal dystrophy and an excimer keratectomy. So you can see figure 7.55. You can see the Schindler dystrophy. A is showing the early lesion. B is showing the late appearance, showing the diffuse haze. Now Francois central corneal dystrophy. So basically these are the polygonal shape opacities in the posterior part of the cornea and it resembles a degeneration like a crocodile shagreen. Francois central cloudy dystrophy. It is not certain that this entity is a dystrophy. It may be clinically indistinguishable from the degeneration posterior crocodile shagreen. Inheritance autosomal dominant has been reported but not clearly established. Almost always symptoms are almost always none. Signs show cloudy grayish polygonal or rounded posterior stromal opacity more prominent centrally. Treatment is not required. Other stromal dystrophies are congenital stromal corneal dystrophy, fleck corneal dystrophy, posterior amorphous corneal dystrophy and pre-Descemet corneal dystrophies. Next is a Descemet membrane and endothelial dystrophy. Very important, very important. Fuchs endothelial corneal dystrophy. It is a very most common corneal dystrophy. This disorder is characterized by the bilateral accelerated endothelial cell loss. So it is bilateral and there is an endothelial cells that are becoming lost. It is more common in women and is associated with the slight increased prevalence of the open angle glaucoma, and it is common F for Fuchs and F for female. Inheritance, most are sporadic with occasional autosomal dominant inheritance. Mutation in the COL8A2 has been identified in early onset variant and in TCF4 gene in most other cases. Symptoms include gradual worsening blurring, particularly in morning due to corneal edema. Onset is usually in the middle age or later. So basically, this is the only dystrophy that present later in life. And what happen is patient usually uh, uh, present with the awakening in the morning due to the corneal edema. So what are the signs? Signs are corneal gatatas, the presence of irregular wart or excretions on the descent membrane secreted by the abnormal endothelial cells. So there will be the abnormal endothelial cells that will be secreting some excretions, and you can see the like a wart like shape in the endothelium. So these are the corneal gatatas. Specular reflection show a tiny dark spot caused by the disruption of the endothelial mosaic. So progression occurs to the beaten metal appearance. So when you beat the metal, and how you the appearance is just like that. Endothelial decomposition gradually lead to the central corneal stromal edema and blurred vision worse in the morning. So what happens is that endothelial basically have a pumping action. It pumps the water out of the cornea. So when the endothelium is deficient and it's not working is not working, it can cause the corneal edema, stromal edema, and the blurred vision is usually worst in the morning. So when there will be stromal edema, there can also be an epithelial edema, and when there will be the epithelial edema, it can be lead to the bullous keratopathy as well. Epithelial edema develops in more advanced cases with the formation of the microcyst and bullae, bullous keratopathy accompanied by the discomfort. Rupture of the bullae is associated with marked acute pain secondary to the exposure of nerve fiber. Subepithelial scarring and peripheral vascularization may be seen in the long-standing cases. So you can see figure 7.57, Fuchs endothelial dystrophy. A is histology of the corneal gatata showing irregular excretions of the descent membrane, pastain, and B is showing corneal gatata seen on specular reflection. C is showing the beaten bronze endothelium, and D is showing the bullous keratopathy. Now treatment is very important. How will you treat? You treat the corneal edema, and you treat if there, and very important is the patient, if the patient present with the cataract with the Fuchs endothelial dystrophy, then how we will treat. So for the corneal edema, we give the hypertonic saline, 5% hypertonic saline, we give lubricant, and for the bullous keratopathy we can also apply the bandage contact lens. But now very important for the case of cataract. So just remember, in a case of cataract, if a patient present with the Fuchs endothelial dystrophy present with the cataract, how will you do the cataract surgery in this cases? So you have to see the corneal thickness and the endothelial count. If the corneal thickness is greater than 400 micrometer and the cells are less than 500 700, then we go for the triple procedure means you go for cataract extraction, and you go for placement of IOL, and you also go for the PKP. But if it's not the case and the endothelium are of sufficient quantity, then what you do is that you do the procedure called the cataract. You do it with the torsional phaco, or you can do with the ECC as well. So treatment is a conservative option, includes sodium topical sodium chloride 5% drops or ointment, reduction of IOP, and use of the hair dryer for corneal dehydration. Ruptured bullae can be made more comfortable by the use of bandage contact lens, cycloplegics, antibiotic ointments, and lubricants. Anterior stromal puncture may be helpful. Posterior lamellar descent membrane stripping, endothelial keratoplasty or DMAC, descent membrane endothelial keratoplasty, and penetrating keratoplasty have a high success rate. So one thing, basically it is an endothelium and descent membrane disease. So you can always go for the DMAC and DSAC in this case. and that have a good results than a full PKP. Option in eye with poor visual potential include conjunctival flap with and amniotic membrane transplantation, a new promising new treatment, topical rho kinase inhibitor with prior transcorneal endothelial cryotherapy seems to stimulate endothelial cell proliferation and improve function. So one is that there will be the rho kinase that has is having a new treatment modality. Cataract surgery may worsen the corneal status because the end of endothelial cell loss, and protective steps should be taken to reduce this. Moderate machine using a torsional phacoemulsification use less ultrasound time than the older machine which uses the longitudinal phacoemulsification are therefore less likely to cause the endothelial loss. A triple procedure combined cataract surgery, lens implantation, and keratoplasty may be considered in eyes with the corneal edema. Corneal edema is less likely to occur after the cataract surgery if the central corneal thickness is less than 630 to 640 micrometers. So I told you in the treatment that how we treat the patient with the Fuchs present with the cataract. Tips are persistent corneal edema may follow cataract surgery in a patient with Fuchs endothelial dystrophy, particularly if the preoperative central corneal thickness is more than 630 to 640 micrometer. Now next is a posterior polymorphous corneal dystrophy. There are three forms of the posterior polymorphous dystrophy. PPCD1 to 3 association include iris abnormalities, glaucoma, and Alpert syndrome. The pathological basis involve metaplasia of the endothelial cell. So basically what is happening in the posterior polymorphous corneal dystrophy, there will be the metaplasia of the endothelial cells. The endothelial cells will take another form of the cells. Inheritance is usually autosomal dominant. The gene VXSX1 has been implicated in PPCD1. PPCD2 is caused by the mutation in the COL8A2 and PPCD3 by the ZAB1 mutation. Symptoms usually absent include with incidental diagnosis, signs of the subtle vesicular band like or diffuse endothelial lesion, and treatment is not required. So we can see figure 7.58 is showing the posterior polymorphous dystrophy, A is showing the vesicle, B is showing the confluent vesicle, and C is showing the band-like lesion. Now next is another very important type of dystrophy, that is a CHED dystrophy. CHED dystrophy is a corneal hereditary endothelial dystrophy. Basically in this case the children, the infants will be presenting with such type of dystrophy, and there will be the diffuse corneal opacities in the case of this CHED. Congenital hereditary endothelial dystrophy is a rare dystrophy in which there is a focal or diffuse thickening of the descendant membrane and the endothelial degeneration. So there will be the thickening of the descendant membrane and the endothelial will be degenerated. CHED2 is more common and more severe form than CHED1 and is occasionally associated with deafness, Harboyan syndrome. So CHED2 is associated with the syndrome deafness called Harboyan syndrome. So CHED1, and there will be the CHED1 and CHED2. Let's see. CHED1 is autosomal dominant with gene locus on chromosome 20. CHED2 may not be distinct from PPCD. CHED2 is autosomal recessive gene SLA4A11. So CHED1 is basically autosomal dominant 1, 2. 1 is autosomal dominant, 2 is autosomal recessive. Photophobia and watering are more common in CHED1 and then in CHED2. So CHED2 have a more photophobia and watering. Corneal crowding and thickening are neonatal in CHED2 and develop during the first 2 years in CHED1. So CHED1, 2, autosomal dominant, autosomal recessive. More photophobia, less photophobia, and CHED2 is developing in the case of neonates, where it is developing in the 1 to 2 year. Visual impairment is usually variable and visual acuity may be surpassed and expected from the corneal appearance. Nystagmus is more common in CHED2, and CHED2 is also usually present with nystagmus, and there will be the deafness Harboyan syndrome. Treatment is with lamellar or the penetrating keratoplasty. So that's it for the corneal dystrophies, and we will see you in the next topic. So this is a patient 7.59 showing the congenital hereditary endothelial dystrophy. A is bilateral perinatal corneal opacification. B, moderate severity in an older children. Visual acuity may surpass than expected from the corneal experience. So that's it. Thank you very much.